No. All right, we're going to kick it off. Thank you all for being the ones to remain on a Friday. My name is Katie Mays, and Peter's going to join me in sort of level setting and talking about stroke system models and ED operations. These are our disclosures. You'll note that not many of us have them, but I need more. We're in this session today going to talk about some key operational challenges in delivering effective stroke care, talk about some evidence-based approaches to optimizing some stroke treatment pathways, and then also explore some emerging innovations in this space. And the thing we wanted to start out talking about is just there are incredible disparities in access to stroke care. Our shop treats a large rural population, and geographic location in particular in the United States really impacts stroke treatment, and that's time to mechanical thrombectomy, but also time to IV thrombolysis. And these are the stroke death rates by county in the United States. You can see again that in rural areas, there's significantly more death rates from stroke. And when we're talking about this issue, you know, we all know that stroke is a really big deal. About 1 in 4 people in the United States will be impacted by a stroke in their lifetime. 12 million people annually, and importantly too, 94 million people are actually living with the effects of stroke. So this is obviously a huge issue, second leading cause of death. But when we're thinking about the landscape of stroke care, just to think about a timeline, in 1996, IVTPA approval was done for stroke. In 2015, mechanical thrombectomy was proved efficacious. And then this year, we finally have FDA approval for TNK. And there's some other advances in stroke care we're going to talk about over the course of this talk, including faster diagnostics, mobile stroke units, AI imaging analysis, and also telestroke networks and how that can impact underserved communities. Ultimately, one big takeaway from the talk is that organized care is really good care. And these are not in order of capability, but just wanted to talk about the definitions of these different JCO commission certifications because they do impact the care that people receive. So primary stroke centers offer 24/7 thrombolysis. Comprehensive stroke centers are sort of the gold standard of care. They have advanced endovascular treatments and also neurosurgical capabilities. Thrombectomy capable centers can do mechanical clot removal. And then you see my own bias here in putting these acute stroke ready hospitals at the top, but these are rural settings that really stabilize and transfer patients quickly. But all of these certifications are really important and ultimately end up, you know, time and time again in studies to provide better stroke care to patients.
Well, thank you, Katie. My name is Peter. You saw my name up there before, and I'll kind of bring the last half of the introduction to a close and talk a little bit about some of the topics that we're going to kind of frame for the other speakers that are speaking. Just as a framework, this is our third didactic proposal that was accepted from our neuro interest group this year. For those in the room, that's pretty impressive. So we're glad that you're here this afternoon, and hopefully you can learn a little bit about this. But as we just heard, you know, fragmented care, which is where most of us, many of us, some of us with gray hair in this room grew up. It was really, you know, from fragmented, incomplete care to really kind of growing our system together in an organized fashion where we now have regional coordination within healthcare systems and tiered level care. We have standardized triage. Still, I think that's one of our great opportunities for stroke in the EMS world, but certainly in the hospital we have standardized EMS approach and protocols. We have quality metrics, which I think is kind of the game changer. Most of us hospitals who declare they want to be a stroke center, whether it's either from a state or a national accrediting organization, have to provide data that demonstrates that they're taking care of patients, and that data goes into a national database and they can compare themselves on how they do against benchmarks and their competitors. I think if you're going to think of anything that changed the game in stroke care and any of the diseases that we all participate in as emergency physicians, I think that is probably it. And then multiple disciplinary teams. We have a bunch of emergency physicians here talking about stroke who some of us have joint appointments in departments of neurology. We work with neurologists. We take stroke call. We do telestroke. Some of us work in the neuro ICU as attending. So multidisciplinary care, collaboration, kind of lack of pillars and silos, really, ultimately, the patients benefit from that care. So we're going to hear, this is just a little tease, as you'll hear about this when we talk about more organized care. We do have thoughts and ideas on how patients should be transported to the right appropriate hospital in the right amount of time, depending upon where they're having their stroke. And as Katie has mentioned, there's still a lot of disparities in our world. In our cities, there's disparities. And certainly rural America has tremendous disparities because there aren't many comprehensive thrombectomy centers in towns of 1,000 or 2,000 people. So how do we create a system that gets people who are having a life-changing disease to that? And there's some recommendations out there. We'll hear more about that. Whether it's a suburban environment, what is a reasonable time to triage a patient beyond the closest hospital, maybe the most appropriate. So let's see, am I hitting the wrong button? Am I stuck here on infinite loop? Oh, there we go. And then, that was kind of a wonky slide thing. And so this was published a few years ago, and this was just very controversial at the time, and it really kind of laid out, maybe when a patient's having a stroke, we should say, number one, I think a patient's having a stroke. Number two, maybe this is a big stroke. Maybe it's a hemorrhage. And perhaps, very controversial at the time when this was published in 2017 by the Heart Association, maybe we should bring them to the hospital that provides the best stroke care. And a lot of hospitals and that create a lot of opposition to that type of flow for patients. But this has really, I think, been internalized and now is in most of our regions is a way we think about stroke care. So pre-hospital stroke pathways, we know, there's initial assessment that involves by EMS, EMTs, paramedics that most of us, or a lot of us in the room help to train. They use the best available or most appropriate severity and screening tools that they're trained on. And then they know where their LVO centers likely are in their region, and they can bring the most appropriate patient to that area, and they have routing plans in hopefully in their urban, suburban regions where they bring them. And then rural areas, often in my area in middle of the country in Missouri, are often linked to larger academic hospitals by telestroke. And that is really, I think, a great way to equalize care across areas where there's disparities. And then technology, not ready for prime time. I know there's a very big mobile health MSU component in the audience sitting back a few rows, but there's great technology out there that is that kind of point of care, bringing the hospital to the patient, and the right place and the right setting can really be impactful for patient outcomes. So I am going to be quiet. Over the next several minutes, you're going to hear about acute ischemic stroke and some of the opportunities, ICH, the other type of stroke that sometimes we don't think about, TIA, which we see a lot in the emergency department, and a system-wise approach. And hopefully you learn a little bit something, and we'll give you some time to ask questions if you have some. With all that said, I will be quiet, and I'll let each speaker introduce themselves.
Hey everybody, my name is Monisha Dilip. I am from Columbia, and I'm from the kind of operational perspective. I'm from the operations interest group, kind of to lend lens for how we can think about strokes and common metrics that you guys have seen in your departments and how we can improve them. So, as we all know, time is brain, and as you guys have heard many times before, and again today, the ED is a very critical point, and the faster that we get patients to imaging and then ultimately to their end goal of treatment or diagnostics can improve their ultimate outcomes. And so we'd like to focus on the key operational metrics from a stroke standpoint, discuss best practices, and then possible common pitfalls and solutions for them. The common metrics that we need to kind of keep in mind, and the ones that everybody is going to be scrutinized for, are door to imaging, door to needle, door to thrombectomy, and treatment rates. The current guidelines are for kind of examining door to needle time and kind of giving our thrombolytics as early as possible for these patients with strokes. And it directly correlates to improved functional outcomes and decreased mortality. But there is a lot of variability between different institutions. Physical layouts can play a large role in this, and imaging bottlenecks, these kind of things can often come up. Door to imaging time, for that same reason, can reduce sometimes our efficacy. Looking at door to thrombectomy for those patients that are eligible for this, for our patients with LVOs, we can create a huge lasting impact. And then the last is treatment rates, and that kind of encompasses all of these. And we look at the functional outcomes and in terms of their risk versus reward, for lack of a better term. We kind of already just spoke about the pre-hospital care advanced enhancements, but apart from the mobile stroke units, also looking at early detection systems, early stroke recognition, and getting them to the appropriate center can enhance all of these times and can enhance basically their onset to treatment times for all of these types of stroke. EMS pre-notification has been demonstrated to reduce door-to-needle time by an average of 15 to 20 minutes. And then again, the mobile stroke units can also improve them significantly. So some potential workflows for stroke management that if you guys don't already have, which I hope that you do, to consider in your departments, are rapid stroke activation pathways, stroke codes, or potentially considering direct to CT pathways that could, if they're pre-notified by EMS versus if the ambulance triage nurse does alert a stroke, bringing them directly to the CT scanner and having the physicians meet them there can be a large component to improving your treatment times. Point of care testing and leveraging that in terms of, glucose and things like that. I assume that that's already the case, but other ISTAT mechanisms, if your CTA requires a creatinine, having that really quickly can also expedite these times. And then having multiple types and parallel processing of neuroradiology. Neurology or radiology evaluating the image as it's being performed, and then utilizing AI for a variety of different commercial products already out there, Rapid AI, Viz AI, that kind of thing, that can automate detection of bleeds or potentially LVOs, and then can accelerate decision making is kind of the current advancements to be able to assist in getting our patients through faster. And the big thing is interdisciplinary collaboration, making sure that your neuro team is on board, your radiology team is on board, your ICU team on board, neurointerventionalists, whatever the case may be. And potentially, if telemedicine is required for your more remote or rural systems, having that in place and very quickly accessible. If you do need a neurologist to be able to say, give the TNK, then you need a neurologist fast. So common pitfalls that we see in many departments are delayed recognition, and that involves a lot of training to be able to recognize non-traditional symptoms. A lot of missed symptoms are posterior circulation, for example, and kind of focusing on that because it may not fit neatly into your NIH stroke scale boxes. System bottlenecks, and these are largely with delays in imaging or delays in being able to have the thrombolytic available and readily mixed. And this can be assisted with dedicated stroke CT scanners, dedicated imaging modalities or dedicated radiologists to be able to respond very quickly in the event of a stroke activation, and that way you can expedite things a little bit more. And there are other communication failures. This can stem from inconsistent handoffs between EMS or from emergency to neurology if that handoff does need to occur, or even kind of the other way around. There can be hesitancy a lot of times on the part of the emergency medicine team in giving thrombolysis, and kind of opening those lines of communication is key to be able to make sure that your patients receive the care as quickly as they can and what they need. Things to overcome these challenges are basically the things that we've just discussed. Continuous education for your provider teams to be able to make sure that they are aware of the newest advancements in when to thrombolyse, when not to thrombolyse, what thrombolytics to use, how to dose it appropriately, what metrics that they need to be looking out for. And this also kind of bundles in the quality improvement initiatives. I work in the quality space right now, and we emphasize a lot that we need to look at these metrics, but don't emphasize sometimes why they're important, and kind of making sure that your team does know why it's important. And then public awareness campaigns can be very huge to be able to have our patients recognize them more quickly. Having those RACE acronyms, things like that, to make sure that your community knows, when to activate a stroke, so that EMS can activate a stroke even sooner. In terms of future directions, the big things that are happening in terms of increasing your throughput through the department, mentioned earlier, the AI-assisted imaging for LVO detection or bleed detection can flag things even earlier sometimes than radiology can pick them up, because often we don't have dedicated radiologists for this. And then AI-driven ED workflow optimization using hospital-level data to be able to predict potential things that can come in. For example, you might notice anecdotally, hey, 7 a.m. is often when we get all these wake-up strokes. If we can have AI using patient-level data and hospital-level data to be able to kind of predict likelihood of different surges, of different diagnoses, that can really expedite our resource allocation and therefore the care. Policy advocacy and standardization involves a lot of nationwide discussions for what we need as a nation, both for medications and for protocols, whether it be for EMS or something along those lines. And then assessing research gaps for mobile stroke units or extended time windows for maybe wake-up strokes and things like that. So the big things we want you to take away from the operational section of this is looking at timely metrics that correlate to improved outcomes, basically enhancing or creating these workflows to expedite care as much as possible. Optimizing the when you get to the hospital standpoint, the EMS pre-notification, and once they hit your door, how can you get them in as quickly as possible? And then keeping the mousetraps and common pitfalls in mind, making sure that your team is educated, making sure that your patients are very well educated, and that can help a lot in the community to be able to expedite care for patients and get better outcomes ultimately. And the future involves a lot of these predictive modeling and policy improvements. And then I will hand it off.
Hey everyone, Joe Miller from Henry Ford. We're going to switch gears just a little bit and talk about some of the metrics around ICH management, and particularly related to American Stroke Association, American Heart Association guidelines, and then also a great resource. Josh Goldstein isn't here today, but it's been around. He and his group has put together a resource called Code ICH, which is a wonderful resource to help educate your residents, other faculty, nursing about ICH management and advocate for it. In terms of ICH, a lot of the comprehensive stroke center metrics around really are based on what can we do to avoid further neurological deterioration, and also reduce heterogeneity in management. I know many times when fortunately things are much better now, but in the past, as soon as like an ICH was detected, a lot of patients would just be back waiting for their ICU bed, and it was kind of hands off, other than some attempts at throwing some labetalol at the blood pressure. But hopefully at your shops, and certainly our shop, things have tightened up quite a bit to have more uniform management of these patients and avoid what we know is going to be potentially further neurological deterioration as the hematoma expands, et cetera. These are a few of the things that the Joint Commission and tracks within the Get With the Guidelines measures includes both assessing the severity of ICH, and there's different score systems we'll talk briefly about, as well as doing procoagulant reversal if patients are on warfarin. Now, the guidelines are a little outdated in that they're specific to warfarin, although we know that a lot of our patients are on other oral anticoagulant medications. And then really looking at the time from ED arrival to transfer. So when we're looking at all these rural centers or stroke-ready hospitals, how are we rapidly getting these patients to a stroke center where they have neurosurgical capabilities, et cetera. So I think this is one area where there's a lot of opportunities for improvements in systems of care for that door in, door out time for transfers, and can certainly impact some of the downstream effects, particularly for some cases that are going to need neurosurgical intervention in a timely manner, whether that's a ventricular drain or, or hemicraniectomy, et cetera. And then working with systems, particularly both pre-hospital providers doing transport, as well as our systems, smaller hospitals that are transferring, to educate the providers to ensure that blood pressure control is started and reaching optimal targets before or during transfer. I think many of you are probably familiar with these, and depending on your system, either you may be documenting them or your neurosurgical or ICU colleagues may be, but there is an expectation within Joint Commission metrics to document some kind of intracerebral hemorrhage score early in their care. And so this, one of the more common ones is called the ICH score, which uses these metrics. It's on MD Calc, et cetera, so easily obtained. But does involve some sophistication in terms of knowing what the ICH volume is. And so whether your radiologists do that or the version of AI software you have does that can impact how quickly you're able to determine the ICH volume. There's also a score called the Max ICH score, which is also similarly useful. It incorporates these variables. Again, it also includes the volume in it, so it does require a small degree of sophistication to determine the ICH volume, but also includes whether they're on oral anticoagulates as well. And this is just data showing the max ICH score. All these scores have been validated and are very predictive of ultimate outcomes. In terms of coagulation reversal, again, like I mentioned, although the guidelines are still related to warfarin, and what the Joint Commission's tracking is warfarin reversal, we know that most of our patients have switched to DOACs, and so whether you're treating with 4-factor PCCs or andexanet alpha for reversal of rivaroxaban, apixaban, et cetera. The guidance, though, is to have rapid reversal for these patients that meets your institutional requirements or institutional guidelines for reversal. And this is a snapshot of the most recent AHA guidelines for reversal agents in ICH. It's a little bit of a busy slide, but essentially, it directs to either 4-factor PCCs or andexanet alpha, or idarucizumab if patients are on dabigatran, et cetera. And then, of course, 4-factor PCCs for patients on the few patients you may see that are on warfarin. And many of you may know there was a recent trial, the NXI trial, that compared 4-factor PCCs to andexanet alpha. And in the end, showed better hemostatic efficacy in the andexanet alpha group, but ultimately, in terms of mortality, there was no difference, and there was a higher rate of thrombotic events in the andexanet alpha group. So I think a lot of our centers are still using either of these agents. I know we actually were using more andexanet alpha, and now we're more kind of, split between 4-factor PCCs and andexanet alpha. Additional AHA metrics that aren't necessarily in the Joint Commission, tracked by the Joint Commission, but certainly guidelines within the AHA include time in the imaging, which for most of our code strokes, I think we're meeting, many of you are probably meeting this, although ICH can be a little more challenging. We were talking about this the other day, that a lot of patients may come in simply with ultrametal status or severe headache, and so can easily wait and triage for extended periods of time. And so, I think there's a lot of work to be done still in helping identify who's at higher risk and needs immediate imaging based on symptoms that don't necessarily scream acute stroke. Again, BP management, so trying to reach BP goals within 60 minutes, glucose management, and then dysphagia screening for patients that are positive for stroke. Current guidelines are reaching a systolic blood pressure goal of 140 for most patients. For some patients that come in extremely hypertensive, a little bit more lenient blood pressure goal. And again, 60 minutes is really the goal. Within our system, nicardipine is certainly like the go-to drug for this. I think at most or highly functioning stroke centers, it's become a very reliable way to bring down blood pressure, although sometimes needs additional agents. And I won't go in detail, but Interact 3, I think, also supported what the guidelines is doing, that's showing that if you do this kind of bundled management of blood pressure, coagulation reversal, and other, great supportive care, patients have better odds of having less disability in the future. This is one thing that a lot of institutions have done. Chris Lewandowski started at our institution to put together an ICH huddle to help teams within the ED, multidisciplinary teams come together and make sure that this timely care is happening either before a patient is transferred or just early in their ED care if they're staying at the same institution. And so it involves bringing together bedside nurse, pharmacist, resident staff, neurosurgeon, stroke physician, et cetera, to go through a checklist and make sure that all these metrics are being met, that we're documenting ICH severity, that we're doing, we have adequate blood pressure control, et cetera. So with that, I'm going to turn it on to Dr. Wira. We'll talk a little bit about TIA.
Thank you very much, Joe. So Chaz Wira from Yale. So we're going to talk about ED patients with TIA. Should they stay or should they go? And so I have no relevant disclosures for this, but the bulk of what we're going to talk about today will be the components of the workup in the ED phase, and then addressing the question of disposition, because there is variability, certainly among many sites, in terms of how this occurs, and we've had evolution at our own site for this too. And so TIA, as Peter mentioned, it is something that we certainly see in all of our emergency departments, 240,000 cases per year in the United States. It's defined as an acute syndrome attributable to a vessel territory that is transient and resolves. The 90-day stroke risk can range from 3% to as high as 18%, depending upon risk stratification methods that are used or vessel imaging. And taking a deep dive into the workup for this, the first step as a part of the workup is risk stratifying the patient with common modalities that are available. Many of you may be familiar with the EBCD2 score, which kind of risk stratifies patients into a low risk, moderate risk, or high risk category based upon symptom duration, characteristics of symptoms, and then the presence of or absence of certain comorbidities. And then there's also the Canadian TIA score, which incorporates other variables like old stroke on CT. And as a part of the imaging, after the initial non-contrast CT that's done, a critical part of the workup is vessel imaging to identify patients with culprit lesions, severe lesions being 50% or more, that place them not only at risk for higher rates of stroke within 90 days, but some of these lesions may present a risk of acute deterioration that's higher within the first 72 hours. And you can see in these case examples here, the image on the lower left is a ICAD atherosclerotic lesion in the M1 portion of the MCA. And then in the panels on the right, you can see a case report of stuttering TIA symptoms that ultimately ended in a watershed stroke, where the patient in panel B on CTA was seen to have a critical 90% carotid lesion that in panel D was opened up in the angio suite with a stent, and they left with resolution of symptoms 90 days later. The most common modality that's used is CTA, but MRA is also acceptable, obviously. MRI, this has become a recommended part of the workup as well. Stroke is now a tissue diagnosis, so if patients do have no symptoms but ischemia on MRI, that's considered to be a stroke and necessitates all of the secondary prevention and further diagnostic strategies to work the patient up. As we mentioned in some sessions yesterday, there is a national availability shortage of access to MRI. ASAP Equal Network surveyed 97 sites, and only 49% had access to MRI. And for those of us who have MR, we know that there's limitations in terms of local availability as well. Availability of techs, hours, the geographic location, maybe at a remote site on our center. Yesterday we talked about our expedited TIA protocol and the 160 patients that went through it, and this is one where the patient was really saved by the MRI that was done, and you could see a small punctate posterior parietal infarct that was seen, and this was a patient who had a low-risk ABCD2 score, transient symptoms of dysarthria and weakness, less than 60 minutes. They were admitted and ultimately had a cardiac echo revealing an apical thrombus, which is another potential etiology of TIA or stroke that can present with a recurrent event and is at high risk for recurrence. Which leads us to discuss and talk about what is the necessary prerequisite cardiac screening that we do for our TIA patients beyond EKG, looking for AFib, telemetry. Many systems as well, as is recommended in the guidelines, have expedited outpatient Holter monitoring as well, looking for cryptic arrhythmias. But one question related to echocardiograms is kind of a little uncertain. We do not at Yale get this routinely in our patients unless they have some higher risk features, but the advisory statements that kind of talk about this leave suspicion up to the selection of the providers. Probably the largest study that we have that kind of looks at the risk of cardiac thrombi is by Perry et al. in Canada, and they found the highest risk was among CHF patients, but also those with other structural heart disease, valvular lesions, CAD, being some of these, which lends the question, could there be utilization of point-of-care ultrasound? The two cases that we had at Yale over the past year, they both had systolic dysfunction and low EFs. This is the other one that was identified. We actually identified a left atrial appendage clot on CTA, and while this wasn't a dedicated cardiac CTA, CT, which has fairly good sensitivity for intracardiac clots, we lucked out in this case as well, kind of picking it up on the CTA that was done as a part of the workup. And then as a part of the system of care, there's obviously other testing that occurs in TIA patients related to hyperlipidemia, diabetes screening, smoking cessation, and blood pressure management as well. And so should they stay or should they go? Should these patients all be admitted, or can some patients be discharged? And then let's talk a little bit about the intermediate option as well of expedited pathways within our emergency department. At our site, like I said, we no longer admit all of these patients, but many sites and talking to people still do. And this can be time consuming in terms of the duration of admissions, and then also costly as well, and may contribute to our boarding in our emergency departments as well if beds aren't available. It is recommended that patients with high-risk features, for instance, ABCD2 scores above 4, culprit lesions, or other risks are admitted. But what about the low-risk patients? There is a body of literature, a few studies now in the modern advanced imaging era that have kind of looked at this, and you can see that of the 4 that were published, they attained high rates of vessel imaging and high rates of emergent MRI, either in the ED or within the first 72 hours of discharge. And what were the outcomes? Among our site, we found, and this validates our imaging, we found critical lesions in 15.1% of our patients. Sample size was 160 from the last year, and 16.2% of our patients had restriction of diffusion indicating a stroke on MRI. We did find that it shortened the length of stay compared to more historical times 5 years ago when patients were admitted. And for all of the studies that were in the prior table, the 30 or 90-day TIA or stroke risk ranged from 0 to 3.2%, suggesting that this could potentially be safe if the system can do the appropriate diagnostics that are recommended. What about expedited discharge and follow-up? Two sites have looked at this. Dr. Bernard Chang at Columbia looked at this in their Raven TIA minor stroke clinic, and the most impressive thing that you all did at Columbia was that you got 95% of the patients into the Raven clinic within 24 hours, which was really impressive. This was published in 2019. The patients were enrolled earlier, so it was a little bit, earlier, potentially without the benefit with all of the advanced imaging techniques that we have, but their outcomes of note, among the 101 patients that had a confirmed TIA and minor stroke, 19.1% returned to the ED or were admitted for a further workup. And then 5 had recurrent neurological symptoms diagnosed as TIA, and 1 had a recurrent stroke after completion of the workup. And one of the questions that was raised at the time, and again, this is different now in this more advanced imaging, is that they only got vessel imaging in 14.8%, and potentially their outcomes may have been even better had a higher rate been done. And so that led to like a follow-up study in France by Leberry, where they did get vessel imaging on 99% of their patients and then had expedited outpatient testing with MRIs. Overall, their result had a recurrent stroke risk after completion of the MRI of 3.2%, but when you read the fine print, the time period range of getting the MRI went from 1 day to 216 days. And then four patients did have recurrent strokes prior to the MRI being performed. And then of the MRs performed, 12.9% had strokes that were identified that necessitated further workup. And so what do we do with all of this information, the 4 studies of expedited pathways, the 2 studies of expedited outpatient workups? It's kind of consolidated in a recent scientific advisory statement that Peter and I were a part of with some other people in the EM realm, looking at this issue of TIA management in the ED. And from the central figure, kind of the take-home points are vessel imaging is recommended, and expedited MRI is recommended either in the ED or within 72 hours of discharge. It's recommended to risk stratify patients with ABCD2 or another similar scale. And if patients manifest high-risk features, either by scales, medical issues, vessel imaging, or have a stroke on MRI, then it's recommended to be admitted. Otherwise, there could be consideration of discharge and therapeutically discharging these patients on antiplatelets. And of note, for the 2 studies that we mentioned in France and at Columbia, all patients were discharged on aspirin or dual antiplatelet therapy in the French study. So what does the future have to hold for this? There are still future research opportunities to maybe look at other biomarkers to risk stratify these patients. One could be cerebral vascular calcium scores extrapolating from the cardiologist. And then with the MRI shortage in America as well, is there a role potentially for other novel technologies like point of care MRI, which could broaden utilization? So thank you very much.
Good morning, I'm Chris Lewandowski, also from Henry Ford, and we're going to try and pull all this together so that some of this makes sense, and to talk a little bit about statewide systems of care. So I have just some research funding, but no conflicts of interest. So in 2019, there was a recommendation for establishment of stroke systems of care by the American Heart Stroke Association, and that really outlined, the basic components of a statewide stroke system. And those components included community education and then primordial prevention, which basically means community level interventions such as pollution control and things like that. And then primary prevention, which is primary prevention on an individual patient level. Then developing your EMS response, developing acute stroke treatment programs, and then secondary prevention, availability of rehab, and then a CQI program. So those are kind of the pillars of what we have to do. But really what you need for a integrated system is that you have to use the existing infrastructure that you have, and you need to be inclusive of all areas of the state, and that the way that we've approached it is to make sure it's regionalized so you can customize it, and that region is accountable and it's coordinated with all the EMS agencies in it. One of the ways that we started this is that we did a set of recommendations that formed the foundation of a written plan. And that worked fairly well. So the strategy in Michigan that we adopted, and I'm wondering how many of you live in a state that already has a statewide system of care? Oh, good. So you already know what life is like in that. So for those of you that don't and you'd like to get it started, I would highly encourage you to pick a young person who's got incredible patience to work with the state, and because it does take time. So that would be really good characteristics of an advocate for a statewide system of care. But, we started working with the Department of Health and Human Services. Back then it was called the Department of Community Health. We did develop an overall plan, but it also included time-sensitive emergencies such as trauma and STEMI and stroke. So that wasn't just stroke going alone. So we actually collaborated with our other colleagues that have to deal with us. And then each group wrote a white paper, which basically outlined what the problems were and what we thought the solutions were and how to bring about a state system of care. And we used that white paper to advertise not only to the community but to the politicians. And so we used that to get legislative support. And the white paper really had, discussions of patient education, how the EMS systems would look, how we would designate hospitals, what transfer protocols we would include, and how we would access rehab and secondary prevention. And then the other thing that it did was it outlined what we needed in a data collection system, and how we would use that data for quality improvement. So this paper that we wrote was published in 2020 after just a short decade of work. And then we did get some legislative support, so we got approval from the state to actually do a system, and then we got funding, and then we had to do administrative rules as to how actually you're going to make this happen. And the administrative rules also require public testimony and hearings. So the first step really was to get this bill done, which we did find support for all three time-sensitive emergencies, and that was really not hard to get support for that, especially since we did have one of our legislators who had a history of stroke in the family and relatives with stroke and became a champion. Then we went on to get funding, which took a little bit while longer, and we were able to get funding through Michigan Senate Bill 82 that funded this whole system. And then when we wrote the administrative rules, it was very nuts and bolts, and we did a lot of inclusion, because once you write the administrative rules, you need to have public hearings so that people who don't agree with you can actually have hearings. And if you include people that you anticipate will disagree with you right up front and they can have their input, then it prevents a lot of rewriting and further hearings, so that the more inclusive you can be, the better. And then one of the things that we did in terms of actually getting some practice on this, we were fortunate in Michigan to have a history of getting the CDC grants, the Coverdell grants. And Coverdell was a senator who had a stroke, and in his honor, they created funding for states to get grants at the community level or at the Department of Health and Human Services level in your state, and then they would help you with databases, and then hospitals would voluntarily supply data, and then that hospital consortium would do improvements. So we kind of got a running start in Michigan by getting Coverdell grants to actually address this problem. And so, you know, I think that's a very important thing to try and participate in. So right now there's more than 21 states with statewide standards. 16 states require stroke centers to participate in these stroke centers, and some states have just developed general policies and procedures for EMS statewide for early notification. So there's a variety of kind of systems in different states of maturity. So in the United States, access to TPA or TNK is not evenly distributed. And you can see that certain states will have real challenges because of the duration of time for access. Access to endovascular capability is also can be limited in many areas, and so these state systems have to actually address those issues. So, you know, in Michigan we do have a standardized protocol for all EMS agencies throughout the state, but each agency or each region can actually pick which pre-hospital stroke scale they want to do. And, you know, this is one of my favorite graphs because it really basically just says, pick something and do it. You know, there isn't a whole lot of difference, and there's a lot of hand-wringing about sensitivities, specificities, and everything else, but to me, you know, which pre-hospital stroke screen and severity scales you use is probably less important than actually using one. So that was our advice to the various regions, and they're working on that stuff. And then, of course, as you have seen already, the American Heart Association had made some recommendation for urban transport as, you know, to be done within 30 minutes with diversions to a comprehensive stroke center, for suburbans, you know, 45 minutes, and with rural transports for 60 minutes. But I think some of those targets, especially in rural areas, and in Michigan we have this whole Upper Peninsula that just has some critical access hospitals, is going to be pretty tough. So we're in the process of working through all that now, and we're gonna try and address those issues. But the real question is it worth it? Is all these systems development worth it? And the answer, according to the CDC that tracks outcome in the states that do have statewide systems, is that yes, it is worth it, and that you get a higher proportion of hospitals becoming stroke centers. You have lower in-hospital costs for stroke patients, lower in-hospital mortality, shorter stays, and higher rate of getting brain scans within 45 minutes of arriving to the door. So these efforts do pay off, and it's real and it's tangible for the patients in your state. So, you know, I think for a lot of people, we started just developing, you know, in-house emergency systems. For me, one of my greatest accomplishments of entire career was to get Detroit EMS to run stroke as a level 1 transport and not a level 3 with knee pain and abdominal pain. And, you know, and then we've kind of moved on from there to try and address issues on a statewide level. So this is kind of a career-long process for those of you that would like to undertake it, but it is well worth it. Thank you.
I have very little to add to those wonderful talks. We have talked about stroke care on many different levels. It is time sensitive and clearly crosses multiple phases of care, and can incorporate not just one hospital, but many hospitals worth of operational planning. Thank you so much for your time and attention. I really just wanted to open it up for folks to ask questions of any of the talks that you've had so far. That is truly my role here. And I don't think there's like a passing mic. So like truly, if you have anything, just shout it out and assign it to somebody. Oh, just kidding, there's. We do have passing mics. I'm on it. Yeah.
This might be just like a knowledge gap of mine, but in terms of the TIAs and like saying that strokes are now a tissue diagnosis with the MRI, what difference do they truly have in like their outpatient care afterwards?
Yeah, that's a great question. I think first, and but Peter, I think you had like data from like a decade ago that, you know, patients with TIA have a stroke. I mean, the risk of a recurrent event within 90 days is higher than those without, just because they've had some etiology to have ischemia. And And so that figures in part to it, but really they are, recommended to be subjected to, all the secondary prevention, typically started on, a statin and, other types of diagnostic studies that need to be done to like see if there's cardiac by or other, PFO or something else that could be in etiology that needs to be treated. There's a higher threshold to place those patients as well, and outpatient health monitors looking for cryptogenic AFib, which may be contributory just because, the game is a little bit changed. And one thing that we're actually also looking at too is that, in our ED, we do so many dry CTs to the head. One of our neuroradiologists is looking at like incidental cold strokes that are found on, routine CTs that are done for trauma or a headache or something like that. And that's not an insignificant number of patients that's seen as well that potentially could, benefit from rapid referral to neurovascular clinics. So it just correlates with, most importantly, a higher risk of a future event that potentially could be larger.
It's finding that threshold or like who do we need to keep in admit it's follow-up.
Yeah, I mean, how many people here are at sites that admit all TIA patients? Yeah, because talking with some yesterday, there are a lot still. Some of our satellite sites, have to do that as well for limited resources.
It's interesting that that the original data on TIAs and rapid evaluation